taking from there, I think Samir has shown us that the spectrum of clubfoot really can come at birth, before birth, and even at mid-20s, and that is the spectrum which we see. And so we have to have a treatment which tailors to everybody. We can't have one size which fits all. So I'll start with a case that this child comes at 3 weeks of age with a bilateral idiopathic clubfoot, and one does the assessment, one does the scoring, you do a Ponseti casting. Counseling is very, very important, as Samir mentioned. And the child, this is how when the cast comes out, the child comes back. So mother is horrified and she refuses the second cast. And I think this is where the challenges come about counseling and about casting techniques. And this is what it's been recommended by Ponseti manual itself, that you have to have adequate cast padding. You have to make sure that you use the fingers in the right place. Don't put undue pressure, especially in the first or second cast, as the tailor head is very, very prominent here. And since you don't have the full abduction at this stage, it is very easy for the beginners to put a lot of pressure on the fulcrum here and cause this kind of cast sore. So just to go through some of the videos of casting, of course this is during COVID time. So here you do put a well padded cast, make sure you can go above the knees. Child should be as calm as possible. The first cast is critical, that you make sure that you are able to abduct you are able to lift the first tray and supinate the foot, and that forms the basis of further casting. As once your foot is supinated, you can gradually abduct in further cast. Make sure you don't leave any prominences or indentation in the cast. Keep moving your fingers as you're casting it, and ensure also that once the below knee part is complete, then only you do the above knee part. Don't try and put the entire cast in one go. So as subsequently you give your casting, you have to ensure that your cast goes through this, your casting process goes through these 4 or 5 plasters. Don't promise the parents they need only 5 plasters. You can, as soon as you're able to abduct the foot up to 45 degrees, then you can think of connecting the hind foot. Sometimes the children may be very, very cranky, so it is worth using something to calm or soothe them. And I find this very useful, using a pacifier. So in our children, they're not like the Ponseti clinic. They all are shouting and howling. So parents have their own, they will put on music. I find you can use glucose solution 20% with a syringe, and you can slowly drip feed the baby, and usually they're quite calm. Obviously follow the Bible. Dr. Ponseti has already laid out the steps. Do not try and modify the regime in any way. So you must follow the sequence of connecting the cavus first, followed by the adduction, the varus, and only then you can cast and do the equinus. The error usually made by the newer surgeons that they try and correct a lot of these components in 1 or 2 plasters. So, and one should understand the biomechanics of it, that as soon as you correct the coronal deformity, the sagittal deformity also improves because of the interlinking of the ligaments. So don't try and force correction in the plane which you don't want to cause a problem. Of course, you score the child with the Pirani score. This is a simple score. It has got its flaws, but at least it guides over treatment. It's not easy to classify clubfoot, which is a 3-dimensional deformity, but at least you have some idea about your correction. So in individual hands, it's a great score to use, and when your midfoot score comes to 0, that's a good time to try and start correcting the hind foot. There are some problems with the scores, and this has been very, very well documented. The most important is the empty heel, because posterior crease may not be deep in every child, and it has got a kind of a ceiling effect. So hind foot score of 2 and 3 may actually mean the same thing. What it doesn't assess is the everter strength, and I think that is one of the most important finding now, that if your child has got poor peroneal or everter strength and no fanning of the toes, in those children you have to really counsel the parents that they will need more plasters, they will probably may need more splinting. So it's very, very important that at the outset you can identify these risk signs. Like I mentioned earlier, don't try and rush to cast. Initially you manipulate the feet, try and feel the bones, try and feel the bony contours, move the foot gently, to whatever maximum correction you can get, and then only you begin your casting. Don't start casting immediately as soon as the child is on the table. It's worth spending a minute or two to gradually strengthen the soft tissues and follow these steps. Correct the cavus, make sure the forefoot is supinated using the first head of metatarsal ray, use the fulcrum, don't put extra pressure on it, and then gradually abduct the foot. So this surgeon attends the first Ponseti workshop and gives a beautiful cast, and after 4 days the mother comes back, only brings the cast and not the child. So this is not uncommon, when you're trying to cast in a cranky child, or you're not following the principles of casting. This is not an unusual finding. So I always counsel the parents that the child may kick in the first 1 or 2 plasters and may actually remove the plaster. So it's not an embarrassment on your part. So it's very, very important that when you apply the cast, you have that first or second cast which is very well molded, and you make sure your knee is flexed over 90 degrees to 100 degrees, because if you keep too much extension, chances are that the cast will slip because the foot is still in equinus. So you have to ensure that you get at least 90 to 100 degrees of knee flexion. So this is the third cast application in a child, and you can see after the cast application, the toes on this side are looking a bit pale. What do you do? Do you leave it alone? Do you change the cast? Or so here, whenever you see this kind of finding, it's very important you don't ignore it. You have to make sure that at the end of your procedure, the child has got a nice pink toes, and there are vascular anomalies in clubfoot. By and large, the commonest cause is vascular spasm, sometimes because of compression. If you're using a tight bandage, especially around the knee in the popliteal fossa, or sometimes when you correct the equinus very rapidly, you will get this kind of pallor. You wait till the toes turn pink. You can wait for about 5 to 10 minutes. Occasionally, one may have to undercorrect, and we may have to redo the cast in case the paleness persists. And these are very important, especially this kind of finding you will get in these chubby feet. Cast slippage, skin problems, vascular issues are very, very common. And so these atypical feet will need a different kind of casting procedure, which I think Rujuta will cover. But you must have a mental picture that whether this foot is amenable to casting in the standard fashion, or whether it needs a modified technique. And this technique is where you try and manipulate the entire foot rather than just the foot deformities. So this I think Rujuta will cover in her talk. Now, once you've done the midfoot correction, you have to prepare for the tenotomy, which is an integral part of the Ponseti regime. So you must assess carefully that the hind foot is empty. You must only do a tenotomy when you know that you are not able to achieve a good plantigrade foot with 15 degrees of dorsiflexion. And also you must have at least good 30 to 40 degrees of abduction. Make sure the lateral border is straight before you plan your tenotomy. Now you must look at the calcaneus, and I can tell you that many times it's not easy to assess the empty heel sign in a chubby child. So occasionally, if a child has come to me with a relapse, or if I feel the hind foot is not getting corrected, it's worth doing an X-ray and seeing whether you're getting any mobility. Also, you look at the skin crease in the soft tissue contour, and you can find the crease is really deep. The key thing is you should not dorsiflex the midfoot, because it would lead to a midfoot break, and that's why sometime in a chubby child I will not hesitate to do intra-op X-rays. And you have to ensure that your hind foot is mobile. If you feel it's not mobile, you can go ahead and do a tenotomy, and then you will see that this calcaneum moves into dorsiflexion. And this is very important, especially if you're not sure about a correction, and sometimes it is not easy to assess the hind foot. So X-rays have a limited role, especially if you're not sure about the hind foot correction. But don't do this. It's worth taking an X-ray, spending an extra half an hour rather than creating a midfoot break, because this causes more challenging correction. You have to start the process again. You have to do a reverse Ponseti casting, and it becomes difficult to counsel the parents that you've caused a midfoot break, and this is an iatrogenic complication. Tenotomy, of course, there are various ways to do it. I prefer a short anesthesia, short GA, where the child is completely relaxed, but I find many people in the West are doing it in the clinic. You can use 11 number blade or a needle. You always go from medial to lateral. You remember that the tendon is not really posterior, it is slightly lateral. And as you put a knife inside, you dorsiflex the foot while cutting, and then you feel a sudden give, and then you can get this kind of a 15-degree dorsiflexion. So normally I would feel the tendon with a small mosquito. You palpate the borders. The tendon is always lateral to the midline, never in the midline. Feel for the taut tissue and always cut medial to lateral. And you should not have a scar more than a few millimeters. One can use a synthetic cast. I usually reserve this for older children, especially if they're more than 6 months of age, because the gypsonoplasters can be broken by active kicking with some of these older children. So to maintain the correction, sometimes you apply a synthetic cast so that the child doesn't come out with the cast coming out prematurely. There are some problems in the tenotomy. You can see there are scars placed medially where you cannot do a complete tenotomy. Sometimes it's placed far medial and you can't reach the tendon, and so there is very high chance of relapse when you don't have a complete tenotomy or a complete correction at the final cast. Occasionally, when you cannot feel the tendon, you can do what is called a forceps-assisted tenotomy, which has been very well described. And then you can use a small mosquito. You can bring the bulk of the tendon out, and you'll be surprised how thick this tendon is. And you cut the tendon under vision, and you can then put a cast. And I find this very useful for these very chubby feet, where you can actually feel the entire tendon. Give the final cast. And then, again, the cast problems don't get resolved. You can get problem in the skin because the child has been in plaster for about 4 to 5 weeks. So you always counsel the parents that there will be some skin changes on the affected side. Bracing again is an integral part of the Ponseti regime. So there are a lot of different types of braces available in the market, which can lead to several problems. And we've got a whole series of these where the child has been applied with this kind of brace right at the outset. And because the skin is delicate, they get these the skin marks. So we've tried to modify this by using a custom-made brace which is properly fitted. Use cotton socks, and we've kind of looked at the causes of failure, brace failures after full correction. And there are some early failures because of pressure sores, intermediate failures because of size issues. Child will start turning, he will start removing the laces, and late failures because the child starts to stand. And I think that is a challenge at every stage of treatment, and it's worth counseling the parents. There are other braces which are available. They're expensive, which don't have a lace, but you have to counsel the parents that getting a brace is not difficult with the current NGO facilities with us. So if you put a rigid brace, you have to ensure that the child wears a proper sock, otherwise they will get this kind of marks, and the parents will stop the compliance. You can get such kind of cellulitis as well. This child needed antibiotics because this Velcro straps were hurting the child so badly they got a severe infection. And late brace problems when they don't change the brace, especially in COVID times, the child is wearing the same brace for 6 months. You can see this kind of skin callosities they get. So this can lead to poor compliance as well. And we've shown this almost 14 years ago about the brace problems in children, and which can affect the compliance with the ill-fitting brace, and especially if the foot is under-corrected. This is very important. If your foot is under-corrected, the brace compliance is always very poor. By and large, it's a very satisfactory technique. If the child is following up well with good compliance, you can end up with a good result, and 90% of children will have a satisfactory outcome. The role of surgery in the Ponseti era is I think is diminishing. In my practice, generally, I would do it when I feel there's a poor follow-up of the casting program, when there's incomplete correction, especially near the peri-walking age around 10 to 12 months, where the parents are really not keen to undergo multiple casting. Somebody who comes back with an incomplete correction at 2 years, and again the child has to now attend school and a toddler play group where the parents really can't come for regular casting. I would definitely offer a surgery, but only after a few plasters, maybe a couple of plasters to get the skin aligned, skin stretched. Also, it will ensure that the parents are going to be compliant in the post-op regime as well. So 18-month-old child who comes first time like this he's a walking child, and he's walking on the lateral border, he will get callosities. Ideally, you can cast him 4 or 5 plasters and then do a minimally invasive procedure this child was coming from a village, so they wanted to get the surgery done. So we opted for surgery. This child had 20 plasters done at an outside center, and I was surprised that the parents actually agreed for 20 plasters. Now they are totally fed up, so they opted for surgery. And the surgery is always an a la carte approach. You cannot offer one surgery to every child. You have to look at the deformity which is persistent. So you start off with a cavus correction by doing a plantar fasciotomy. If the posterior structures are tight, you do a posterior release. And what we do for the forefoot is an abductor hallucis tenotomy, which we've described. In a dynamic foot, we can always do a split tendon transfer. And in a late presentation, you have to do a full blown release along with the column shortening. So this child was an 18-month-old child, had a bilateral clubfoot, and we do 1 foot at a time, but this was a hemi-Cincinnati approach. So this child underwent surgery in the same sitting. This is a different child. You can see the scar of the hemi-Cincinnati. One responded to Ponseti, and so this posterior release is very, very rewarding. I'll show you some slides of this. Also, the child who, when they present with this kind of dynamic over correction, over supination, I always add abductor hallucis tenotomy as well. I don't know what the benefits are, but certainly it helps reduce the forefoot adduction, and we are still looking at our long-term results with this. So I would combine this either with the posterior release or a TA tenotomy. Like this child underwent abductor hallucis tenotomy with a posterior tenotomy. So this is a child, 22 months of age, had a relapse following a tenotomy. And this child, we did a hemi-Cincinnati approach, did a posterior release, open TA lengthening, and then ankle joint capsulotomy, and a subtalar capsulotomy till we could get 15 degrees of dorsiflexion. I can tell you, when you do a tenotomy, it's not a benign procedure. Whenever you open these or you revise these, you will find the scarring is right up to the capsule. And occasionally, when you do a retenotomy, you may not find the gliding. So in those cases, it is better to do a mini open, because you should try and get at least 15 degrees of dorsiflexion with whatever technique you're convenient you're able to do. So retenotomy sometimes doesn't work very well, and I've seen that it doesn't glide. So I'm happy to do a mini release, and the incision heals very well. In the older child, they will need a comprehensive release, and that I mean is a posterior medial release along with the lateral release, and there are various ways to do it. So in my hands, I do it prone with what is called the Cincinnati approach, where we take the incision right from the base of the first metatarsal up to the lateral malleolus, and so we attack the structures on the medial side first, isolate the nerve, which is always free from the neurovascular bundle. So release the FHL, the FDL sheath, the tip post, release all the capsules on the medial side, and then in the end you repair it with proline, and you always suture in equinus, and you can see the release of the fasciotomy as well, the plantar fasciotomy. Sometimes the foot looks very ghastly like this in the older child, where when you've done a comprehensive release, and you can see that the amount of correction you can get and the amount of skin which is left uncovered. But believe me, this really heals very well if you cast them in equinus for the first 4 weeks, and then you gradually stretch them. So this is an example of the skin closure. I use absorbable stitches. Always I use a wire, a talocalcaneal wire, and a wire from the first ray to the calcaneum to maintain the correction. Occasionally you can even leave the entire thing open if you want, especially if the skin condition is poor, and you will find that you can come back in 3 weeks and close them. I very rarely done that. I always close the skin primarily. And you keep the cast in equinus, and you will find after 4 weeks, as the skin heals, you can come back and correct the deformity, and you can get a well-healed scar without any problems. The turquoise release, which is the classical posterior medial release, either you can do from a straight medial incision, or you can do a dual incision like described by Attenborough. But the key structure is the abductor hallucis tendon. The abductor hallucis muscle is the door to the tendons. Once you elevate this muscle, you expose the medial structures, the medial tendons, the medial capsule. So you must do a very good excision of this muscle and let it stretch itself, and then you can go underneath and expose the tendons and the capsules. So these are structures to be released. I will not go into detail. It's all there in in theory. But the essential part is to preserve and repair the sheath of the tibialis posterior. Always derotate the talus. That is the key thing. After you do all this fancy release, make sure you are able to turn the talus from external rotation to internal rotation. Put a pin, put a cast for 12 weeks with an interval cast change at 4 to 6 weeks to check the wound. You can remove the wires at 8 weeks, get the child measured for splints, and finally remove the cast at 12 weeks. Now, of course, surgery will always lead to some stiffness, but it is better to have casting for a good amount of time so that the compliance with the splinting is good. And you can get a good result following a release like this. So this child had a tip and transfer with a Cincinnati release, and you can see the foot is very well plantigrade. It is always better to get a mild flat foot than a cavus in these clubfoot children. So this is another child who underwent a posterior medial release. I always get the splints ready by 8 weeks when they undergo a cast change, so that the splints are available, and the child then continues to wear these full time. Role of tip and transfer again is very limited in my practice. About 30 to 40% of children, typically around 3 to 4 years of age, when they have dynamic supination, and you can do a split tip transfer or a complete transfer. The key thing is to identify the tendon from the medial side, harvest it here in the lower part of the leg, and then pass it through the third cuneiform. So this is how I would do it. I would harvest the tendon from a small incision, and then suture it on the button underneath there with the felt, so that you can cut this at the end of 6 weeks. And you can find that after the tendon transfer, the everter power really improves dramatically. So this is a child who underwent this procedure. You can see the tendon is harvested. I use a tendon stripper to harvest half the tendon, and then you can either use an anchor for the older child, or you can suture it with a drill hole in the third cuneiform and over a piece of felt. For the older child, I've also used a 2.5 mini anchor made by Smith & Nephew. And you can see the results of tip and transfer. They are very, very rewarding. Occasionally, I've combined this with a medial release as well as sometime abductor hallucis tenotomy. And you can see as the child is dorsiflexing, you can get a good eversion of the foot. And you can see it here, the wound is well healed. That's the line of pull, and the feet are plantigrade. So finally, tips and tricks in Ponseti: never do pronation. Always use the head of talus as fulcrum, but don't press it too much. Don't try and correct equinus before you do everything else. Always plaster above the knee. Don't try and cast in an active child who's fighting against you. Make sure the child is calm. Don't use excessive force. Always have a good assistant. Have adequate padding, not too much or too less, and you must have good molding. Ultimately, the collapse in bracing will lead to relapse, and we found that in our practice, 70% of relapses occurs because of poor brace compliance, and that has been very well described. So the maintenance phase is very important, and I think Alric is going to cover the relapse clubfoot, which we've already covered in 2013. The relapse pattern is not varies depending on the abduction orthosis the child uses, and I think that is the key today. You may get a good casting outcome, you may get a good brace outcome, but you have to kill the relapses, and that is the real challenge. With children coming from various parts of the country with limited finance, with limited resources, and that is the next challenge. So I think I will end my talk here. If it is any